Hi, my name is Diane. I ended last week with the methadone awareness test, so we're going to go over the answers today. Hopefully this will give you some insight into the myths and the truths of what's going on. So the question one was, is methadone trading one addiction for another? And the answer is false, because methadone patient is not dependent on their medication. Which means they're not addicted. Methadone is classified same as if you were a diabetic and needed insulin. It's a medication that you need to keep your body well, not that you have to have it. And you can find that in the Diagnostic and Statistical Manual of Mental Health Disorders. Experts in the field feel that compare an individual on methadone therapy to the same as a diabetic. It's there to control their disease, not to cure. So question two, a pregnant woman should withdraw or lower their dose of methadone so that the baby is not born addicted. Again, the answer is false. Withdrawing the mother or results in a higher risk for the baby and a higher infant mortality. Current research is showing that doses below 60 milligrams are not effective and hence not appropriate, and that low dose policies for pregnant women and non-pregnant patients are associated with increased drug use as well as reduced program retention. Medical withdrawal of opiate-dependent women is not recommended in pregnancy because of the increased risk to the fetus and intrauterine deaths. Toward the later trimesters, increased doses and or split doses are often more effective to keep the abstinence down, as well as safer for the baby. And studies do show that there are direct correlation between increased dose and increased birth weight, the most reliable indication of neonatal health. Since methadone does not cross the placenta, only about 50% of the neonates have any symptoms of abstinence, and they're usually mild. The neonatal abstinence syndrome is heavily treated and does not have long-term effects on the infant. Thousands of children have been born to methadone mothers, and many of which are now adults and living normal lives, indistinguishable from anyone else. Question three is, methadone gets into the bone marrow and rots the teeth. This is also false. Few drugs have been studied as extensively in humans as the methadone. Hundreds of thousands of people have been maintained on methadone since the treatment was developed over 30 years ago. Methadone and methadone therapy are so tremendously misunderstood for many reasons that the study indicating such serious side effects would have been massively publicized, and most certainly resulted in ending the program. The only side effects of methadone in stabilized patients, however, are increased swelling and constipation, neither of which affect the majority of patients and can usually be handled with a dose adjustment. As used in maintenance therapy, methadone is one of the safest medications known and even safer than aspirin. Question 4. Methadone suppresses the immune system, so that HIV positive methadone patients should be encouraged to withdraw. That is also false. The methadone normalizes the endocrine system and immune functions that are damaged and dearranged by injection of the pure street narcotics. Recent studies have demonstrated that methadone normalizes the immune system and the endocrine function and may even enhance in some instances. Number 5, methadone. It is necessary for a methadone patient to take, if it is necessary for a methadone patient to take pain medicine, they need not take heavy narcotics because the methadone blocks the pain. That question is false. Methadone patients feel the normal range of pain. Methadone is administered to treat the addiction to the tolerance of the analgesic effects quickly, and methadone patients feel the same normal range of pain that anyone else does. Due to the cross-tolerance and blockade effect of the methadone, they will usually need a significantly higher dose of narcotic analgesics and more frequently administered. Not understood by a lot of physicians is the blockade effect of methadone that protects the methadone patients from respiratory depression. The clinicians may not be concerned about administering too much. Question 6 is methadone causes patients to become alcoholics or cocaine abusers. That is also false. The secondary drug use is related more to the patient's drug use prior to entering the treatment. Methadone maintenance is not a treatment for non-opioid drug use. While a significant minority of methadone patients do become alcoholics, of these 98% were heavy or problem drinkers prior to the induction and prior to their introduction to heroin. The statistics for cocaine abusers is similar. The patient who responds best to the methadone maintenance treatment is the one who has long-term history of opioid use and attempted several treatment options besides methadone. Question 7. Methadone is more addicting than heroin? That question is also false. Question 1, we explained the difference between addiction and dependence. In terms of the physical dependence, double-blind studies done at Lexington have demonstrated that when comparing the withdrawal symptoms of patients maintained on equivalent doses of methadone and short-acting opioids like heroin, those of the former group were less severe than than those of the latter group. Withdrawals from methadone dose last significantly longer than that from the short-acting opioids, however, and thus this clearly contributes to the patient's misconception that methadone is more difficult. Question 8 is methadone patients should not be allowed to operate heavy equipment or machinery. False. Stable methadone patients cannot be distinguished from control groups by way of anything short of toxicological screening. Extensive research has demonstrated that stabilized methadone patients are indistinguishable from control groups in cognitive functioning and motor skills. And in fact, for some tests, methadone patients were superior group. Question 9. Methadone was named for Adolf Hitler, which is also false. Dolafine is a trade name and was given to the methadone in the United States. Methadone is a generic name and was given to the methadone in the United States. This is very commonly believed myth. It is, while it is true that methadone was first synthesized in Germany before World War II, they called methadone excuse me, Hochist or polyamidin. While their first studies in Germany, its properties as a useful medication to withdraw addicts was not discovered until after the war at a public health service hospital in Lexington. And question 10, when autopsies are done, the bone marrow will be dyed orange. This is also a common myth. When asked, but it comes from the same kind of thinking, or rather lack of thinking. When asked the person who first told us this myth why they thought this was true, the answer was the same thing as always: because everyone knows it's true. So here's the challenge for you test takers. When you hear myths about methadone, talk to the person. Ask them where they heard it and if they have the scientific evidence to back it up. The point is that patients are the ones that can stop the myths, because they come from us. Myths help patients fill the void when the programs do not provide adequate information. So next week, I believe we're going to have a video from a doctor whom I know regarding Suboxone. So again, my email is dwood.4@yahoo.com. If you have any questions, feel free to email me. I'll be glad to get those answers out as quickly as I get them. Talk to you soon.